guys. Hi, everyone. Thanks for joining. Can you guys hear me okay?
Yep, you sound great.
Okay, great. So as you know, September is Prostate Cancer Awareness Month. So thank you to Boston Scientific for hosting us tonight and putting this all together. This is really cool. I think we're all a product of our Zoom environment these days. This is going to be more entertaining than watching the Cardinals game tonight, although Wainwright's pitching tonight, so hopefully we'll get a win. Okay, so what I'm going to do is I'm going to walk you through, well, here's my locations. You can find us on the web. Oops, let me go back. You can find us on the web at stlurology.com. We have nine main locations and total of 15 locations around the Metro East. So chances are we're close by. Okay, what I'm going to do tonight is I'm going to spend about 20 to 30 minutes talking about prostate cancer, anatomy, statistics, diagnosis, some various treatment options, and then we'll open it up for about a 30-minute question and answer. And some of you guys and gals have submitted some really good questions, and we're going to get to as many of those as possible. So that second half of the presentation will be interactive. And then I'm going to talk finally about an exciting new treatment that Boston Scientific offers to reduce the side effects of radiation called space OAR, and I'll explain what that means. So first of all, let's talk about some anatomy, okay? A lot of guys who are diagnosed with prostate cancer say, well, what is the prostate? Well, the prostate's a reproductive organ, okay? So men urinate through the middle of their prostate because it's connected to the testicles and the vas deferens, which allow sperm to get to the outside world. So as you get older and you're not trying to make babies anymore, the prostate just gets in the way, okay? It gets bigger, it gets obstructed. So the bladder sits on top of the prostate, the rectum is right behind it. We can biopsy men right through the rectal wall because the abdominal cavity is up here. So I don't know if you can see my pointer or not. So that's just a very cartoony anatomy lesson, but it kind of gives you some perspective. So prostate cancer is very common, okay? 1 in 9 men in the US will be diagnosed with prostate cancer during their lifetime, okay? It's the second leading cause of cancer death in American men behind lung cancer. We're not exactly sure we know why it's more common in the United States. It probably has to do with the Western diet, the high fat, high salt Chick-fil-A diets that we all love. Epidemiologists have really worked hard on this. Okay, so in 2018, there were 164 plus thousand new cases of prostate cancer. Almost 30,000 men died of prostate cancer in 2018. However, the 5 and even the 10-year survival rates for all stages, high grade, high risk prostate cancer, is very good, 99%. I think that is a testimonial to how good we are at treating it. There's been really a renaissance period over the last 5 or 6 years with therapy for advanced prostate cancer. There's 6 new drugs on the market. So, even for men with formerly very aggressive prostate cancer diagnosis, we're now really good at treating those. So how do we detect it? Well, the most common way it's detected is with screening, okay? So that's a PSA, a blood test, which is prostate-specific antigen, okay? And a digital rectal exam. We recommend that every man over 45 gets a PSA for average risk. If you're high risk, meaning that you have a first-degree relative, a father or a brother that has prostate cancer, we start that at 40. And then depending on the level, if it's less than 1, then you don't need one for 2 to 4 years. And if it's between 1 and 3, we do it every 2 years, and so on and so forth. So non-screen detected prostate cancer is usually worse, and that's when a man presents with symptoms of advanced prostate cancer, such as pain, bleeding, urinary obstruction, sometimes kidney failure because the kidneys are obstructed from metastatic prostate cancer. So if it gets to that point, it's usually a trickier problem to fix. Really, the only way to confirm a diagnosis, though, is with a prostate biopsy. I have a lot of guys that try to negotiate their way out of a prostate biopsy because nobody likes it, of course. And we use MRIs a lot as an adjunct to diagnosis and for monitoring men with low risk prostate cancer. But the only way is to get some tissue, look at it under the microscope. So how do we get tissue? Well, there's a couple different approaches. The most common approach is on the right-hand side, this transrectal approach, where we put an ultrasound probe in the rear end. It takes about 10 minutes. We do it in the office with a little bit of local anesthetic. Okay, so we deaden the prostate, and then we take sort of a mental templated 12 needle biopsy, 6 on each side. And we get a lot of information from that. The other way to do it is with the transperineal approach, and that is through kind of the bicycle seat area between the rectum and the scrotum, where you go directly into the prostate and not through the rectal wall. There's some school of thought that feels like this is more accurate and perhaps a less infectious risk, but I think with targeted antibiotic therapy, our practice really has less than 1% prostate biopsy sepsis or bacterial infection, systemic bacterial infection. So I think we've come a long way with that. Okay, we get a lot of information from the biopsy though. So if cancer is detected, we're able to grade that, and that's the famous Gleason score. And Gleason was a pathologist, and he came up with a grading system to essentially communicate with the clinician the aggressiveness of the tumor. Okay, so Gleason is on a scale of 1 to 5. We almost never see 1 and 2. So it's really 3, 4, or 5, low, intermediate, and high grade. Then you get 2 numbers because sometimes it's a blend. So you get the most common and then the second most common, and that compiles your Gleason sum. And so really on a scale of 6 to 10. So 6 is considered low risk, 7 is sort of intermediate, and greater than 7 is high grade. So Gleason was kind of a visionary, and it's been around since the 80s. We then compile that with other factors such as PSA velocity, how fast does the PSA go up over time. Genomic testing has been around for probably 10 years now, and that is where we look beyond the microscope at the genetics of the tumor and how fast are the tumors replicating and dividing. There's 3 different types, but essentially you're looking at how fast the tumor is growing. And then what's the volume of the tumor? Okay, so if there's a difference between a small amount of low-grade tumor and a high amount of intermediate or high-grade tumor. And then there's other different models where you plug in Gleason score and age and number of cores that are positive, and it spits out some different statistical outcomes. Okay, once we have a diagnosis, then we move to trying to figure out what's the best way to treat it. Okay, and there's lots of options. Okay, active surveillance is perfectly acceptable and very popular for men in their 60s and 70s with low risk disease, and it's very effective. There's a long wide window here, and about 70% of these at 5 years don't progress. So active surveillance obviously mitigates any potential side effects from therapy, and it's been shown to be very safe. Radiation therapy is obviously something that a lot of men choose, and then we can also remove it via multiple surgical approaches. And we try to balance the risks versus the side effects versus the upside. So, and here's a little bit more detail on that, kind of basically what I said. About 90+% of prostatectomies nationwide are done robotically these days. Okay, so that's the Da Vinci robot that some of you have heard about. We do a lot of those in our practice. And there's multiple different flavors of radiation. I'm going to focus on intensity modulated radiotherapy tonight. We're not going to really talk about brachytherapy. That's a seed implant. Sort of more historical than kind of mainstream these days, because the computing power and the technology has gotten so advanced with external beam radiation. Okay, so briefly, radiation therapy. Okay, so you use directed radioactive exposure, so essentially a high-powered X-ray to kill cancer cells. It basically breaks the DNA in the cancer cells so that they can't multiply. And ultimately, it also helps kind of devascularize the tumor so that they're choked off from the blood supply. But that comes with some side effects. Remember your anatomy lesson, right? The prostate's in a tricky spot. It's not like radiating, a head and neck or a breast, which is more on the outside of the body. It's down deep down in the pelvis and has a lot of vital structures right around it and through the middle of it. So we try to mitigate the bowel dysfunction and the urinary dysfunction and by multiple strategies. And we're going to talk about space OAR here in a minute. Again, here's the breakdown. Image guided radiotherapy, that's where we put fiducial markers in to lock the beam on so that if you move the treatment moves with the prostate. 3D conformal radiation is more old school. We don't really do that anymore. Intensity modulated radiotherapy is the current iteration of that. Stereotactic body radiation, that's SBRT, that's CyberKnife, which you may have heard of. Okay, that's where you can consolidate the total dose into 5 high-powered treatments. It's a relatively new technique, so we don't have 10-year data on that yet. And proton therapy, there's only a few centers nationwide that offer that. Barnes is one of them, so you can get that here in town. And internal beam, if you will, radiation therapy, that's brachytherapy. And brachytherapy was developed 30 years ago or so to radiate the prostate from the inside out. It made sense at the time, right? Because the external beam was not very accurate. So guys had a lot of side effects, such as, skin changes and bladder changes and bowel problems. And so it was genius, right? We'll just put radioactive implants in and then irradiate the prostate from the inside out. The problem with brachytherapy or seed implants is that you put 100 red hot grains of rice in the prostate, and then you have to urinate through the middle of it. So guys that have side effects from that are miserable. And so we've sort of gotten away from that. The implants are permanent, but the radioactivity dissipates over about 6 weeks. Okay, so again, the problem that we try to mitigate with radiotherapy is toxicity, right? And there's lots of strategies. Okay, so you can see here on the left, the red is the outline of the prostate, and then the green and the blue are the sort of the zones of therapy that they use to capture any cells that might have spread outside the prostate. You can see the little bright, whoops, go back here. You can see the little bright and shiny things in the middle of the prostate. Those are the fiducial markers. But you can see on the right-hand side here how close the rectum is to the back of the prostate, as we know. And then remember that the urethra runs down through here too. So bladder here, urethra runs down there, and then out through the penis. So, all of these things are vital for daily function. So how do we reduce rectal toxicity? Well, space OAR came along a few years ago, and it's been really a wonderful adjunct to radiation therapy. And I'm not going to run through this study, but basically it's been shown statistically to really reduce the risk of gastrointestinal and genitourinary, meaning urinary side effects as well. There's very, very little downside to putting this in. So what it does, this is your anatomy lesson revisited. Okay, so rectal radiation is unavoidable, but if we put a spacer in there, a space OAR gel, which has the consistency of Jell-O, essentially, it's a temporary thing that dissolves starts dissolving in about 3 months, and it's completely gone in 6 months. It essentially gives the radiation oncologist a backboard so they can radiate the prostate, because most prostate cancers are back here. That's why we do rectal exams, because we can feel about 75% of prostate cancers are in this posterior part of the prostate. So you really need to treat this area, but you obviously you don't want to radiate the front wall of the rectum if you can, because that leads to rectal urgency and diarrhea and blood in the stool and lots of other less pleasant things. So it's really been a wonderful thing. It's super easy to put in. We do it in the office with a little bit of local anesthetic. Most guys say it's not even as bad as their biopsy. So super easy, effective. Okay, OAR stands for organ at risk. Okay, and I kind of already said this, but really reduces the rectal toxicity, which can impact your quality of life. anecdotally at least, there's, that leads to an overall better sense of well-being and quality of life, such as urinary and sexual side effects that men get as a side effect to prostate cancer radiation. So, again, it's gone in about 6 months. It's designed to reduce the rectal wall exposure, and it's really pretty simple to put in. I've probably done 100 of these. Okay, so it's made of polyethylene glycol, which is antifreeze. Again, 8 times more likely to have a decline in bowel, urinary, and sexual quality of life when compared to space OAR at 3 years. So that's the control group. So these slides get a little bit redundant, but more space equals fewer, and mo better. It's been reviewed in 75 peer-reviewed journals in over 50,000 patients nationwide. A quick testimonial here. I want you to meet Henry.
I was diagnosed with prostate cancer. The level of cancer required medical intervention.
When you're trying to radiate the prostate with radiotherapy, you always have to add in a margin. With SpaceOAR, it allows us to treat the prostate without compromising at that border between the prostate and the rectum, because that border isn't there anymore. There's a big space. By increasing that physical space and decreasing that radiation dose, it really preserves a man's quality of life. Having a space there between the prostate and the rectum reduces a lot of that worry.
The SpaceOAR treatment is not a process or procedure that needs to be feared in any way.
I strongly encourage all of my patients who are having radiation to have a spacer placed before treatment.
My greatest hope that it would be available to all persons everywhere.
All right, let me see if I can move on here.